And you can email us on this lengthy email address, or you can just send me a text or Julie a text and we'll add you onto the groups. And you can watch the recordings and the past recordings as well. We have another exciting talk this week, and I'm just going to go through some basic etiquette for this talk. So please ensure you're muted at all times, except of course to ask a question or comment. And you will have about 10 to 15 minutes at the end of the talk Q&A. Please use the reaction button to raise your hand, or use the chat box by writing your name. So we know you wish to ask a question, or type a question in the chat box, and we'll try to get to as many of them as possible. And over to you, Prof. Martin.
Thank you very much, and welcome everybody to this webinar given by Associate Professor Koert de Waal from John Hunter Children's Hospital in Newcastle. And he's chosen, or he's been given, a very interesting topic, which is a couple of the really important things that we try to balance out in the NICU: fluids, sodium, the PDA, and what impact they all potentially have, if any, on bronchopulmonary dysplasia. So I think a very relevant talk for clinicians at the bedside. And I'm looking forward to Koert, in his normal, inimitable style, being able to put all these things together and inspire us to review our practice and possibly develop research around some of these topics which need a bit more information. So, Koert, looking forward to the talk.
Thanks, Martin. Let me find my screen. Can you see that?
Yep.
All right. Thanks, Martin and Rahul. And yes, I'm going to try and indeed sort of stitch these three things together: fluid, sodium, and the PDA, and what or if they have anything to do with particular BPD. But I will also talk about some other sort of morbidities in that same line. What we're going to do is I'm going to start with a case example of the problem, which I bet most of you would recognize. We're going to talk about water and sodium physiology. Then we talk about the actual interventions, fluid, sodium, and these outcomes, and hopefully close off with how we can search for the optimal fluid and sodium balance in our everyday practice. So this is the case. It's a severely growth restricted male infant at 26 plus 2 weeks, pregnancy-induced hypertension, suspected choreo, cesarean section, delayed cord clamping, intubated, some surfactant, and sort of a series of what to be expected medications: antibiotics, caffeine, had a low hemoglobin, was given red blood cells, and could actually quickly be extubated to CPAP and then low amount of oxygen. Baby was stable overall. CPAP, fluctuating oxygen, no apneas, blood pressure was good for this particular baby. Central lane was placed, and then one of the typical things we see in these small little babies is that the sodium was rising from 140 to 158. And the question is then on the floor, should I give more fluids? We explore some of these babies a bit, and we look if there's anything else to be seen. This is just a long axis view, and we look at stroke volumes, which you see on the right, and the stroke volume variation, particularly with breathing. And we look at the right atrium, which you can see a bicaval view, if the right atrium is big, if the vena cava inferior looks sort of acceptable, the SVC diameter. But these are really not the most helpful tools, I think, in this particular question. We know that hypernatremia is associated with fluid intake, because it's been routine practice for many decades here in Australia, but also in other regions, to give more fluid in preterm infants with hypernatremia. But there's actually very limited information about it, and I will show you that. And the balance on the floor and at the bedside is, well, wait a minute, that high sodium is a marker of dehydration, and this baby's at risk of kidney injury, so I should give more fluid. Or on the other end, well, more fluid, and is there then a risk of a persistent PDA or BPD? This is one of those studies which explored 66 very young infants, less than 27 weeks, and they showed that 30% had a sodium of over 150, and even more, of course, 70% had a sodium over 145. And they said in that paper, look, all these cases resolved, and that's what you can see in the graph, is the fluid intake on different days after birth, which was increased, particularly in the babies with a higher sodium. And the mean increase was about 27 mils per kilogram per day. So to sort of grasp this whole problem, I usually go back to physiology. And I will start with talking about body water and sodium distribution. This is a schematic representation where your total body weight is divided into solids and into fluids or water. And total body water has two main components. It's either intracellular, and then it's divided with the cell membrane to extracellular. And extracellular is then divided into the interstitial fluid or the interstitium, and what kind of fluid is in plasma, the plasma volume, which is divided by a capillary wall. And both sodium and water can sort of move around these compartments quite readily, depending on osmotic kind of pressures and other active processes. So sodium is generally low intracellular and higher extracellular. So how is this then regulated? And there's two sort of, as usually is, there's a positive and a negative sort of balance. On one end, if blood volume or blood pressure is low, or there is a low sodium measured in the distal tubule of the kidney, then you got this sympathetic stimulation, prostaglandins kick in, and they all sort of connect to the renin-angiotensin system and the ADH system. And the effect of the renin or the RAS kind of system is to vasoconstrict, to get sodium and water retention and increase your cardiac output. And this is opposed on the other end by, if blood volume and pressure is actually high, then the natriuretic peptides come in. They are released usually to a stretch within the ventricles or by parasympathetic stimulation, and they do the opposite. They inhibit renin and their activity of it and do vasodilatation, sodium water excretion, and reduce preload. So there must be a balance between these two systems to make our water and sodium optimally regulated. So if we look at the baby, what they have to do, they have to start from this fetal condition where actually prostaglandins are high, RAS system is high, ADH and vasopressin is actually high, and the natriuretic peptides are low. Then they are born where there have to be a massive change in all these particular placental regulated sort of prostaglandins and RAS system. There will be left atrium stretch, so the natriuretic peptides will automatically go up, and then you get this normal balance situation, balanced hormone and a low sodium intake. What we've learned is coming from, particularly in the early phases, in the first day of life, is mostly from some small older newborn studies, but not too much, and actually most of it comes from animal studies. This is a study from Sega looking at glomerular filtration rates in the first 24 hours, and from the fetus it's slower, and you see that slowly sort of climbing up, which we recognize with a slowly increasing urine output early after birth in the normal newborn. However, the urinary sodium excretion rate, or the fractional excretion in sodium, which are depicted here in white on one end and in black on the other end, actually is decreasing in this time. So they're trying to compensate these hormonal balances are changing. And some papers, they call this the healthy newborn hydration model. I like this. This is a very nice descriptor of what a healthy newborn goes through. As a fetus, which generally has hyperhydration, more water, and a lower sodium and a high extracellular fluids. Then labor happens where the maternal fluids are naturally sort of constricted into mom, oxytocin go up, fetal ADH goes up, and there's a low urine output. And birth happens, and suddenly the baby is, detached from all these hormonal influences from either the placenta or mom, and changes its own hormonal balances within the baby. Then in the first day, the normal ADH goes down. There's a low intake, but there's a fluid shift from interstitial to intravascular to sort of compensate for that particular mechanism, and an increased urine output. And then you get the final days where the baby is normal euhydration with a normal serum and a normal extracellular fluid. Strangely enough, though, if you look at, for instance, breast milk and how much sodium is breast milk, then you find that breast milk is relatively sodium deficient. It might be high in the very first days after birth, but very soon thereafter, actually, the sodium content in normal breast milk of term pregnancies actually reduces rapidly. So this makes you think, where is that sodium then coming from in this healthy term baby? Sagan looked at this and they did some modeling, not necessarily measuring, they did some modeling, and they came with a new suggestion of looking at this sodium, maybe not as a 2-compartment model, but as a 3-compartment model. With their modeling, they found that particularly later in gestation, there are unaccounted electrolytes to be found. And in this 3-compartment model, the intracellular sodium will still be low, the extracellular component, your sodium will be high, but he suggested that there might be a 3rd component, an extra component with osmotically inactive sodium, which is stored without water. And this is an interesting concept. This is not being proven, but it sort of explains why a baby can sort of survive and have a normal sodium without that much sodium in the breast milk. So they conclude in these kind of descriptors that the renal and water sodium handling immediately after birth is adapting from fetal circumstances. So this is the renal, water, and sodium transition. And you have your lungs which transition, your heart transitions, your kidneys transition, and your hormones transition around birth as well. So the question which is then raised by me as a neonatologist, okay, well, what then happens if you're born preterm? Is that any different? Well, of course, that is different. This graph shows the amount of nephrons on the left side and the renal mass on the right side per gestation age. But what is probably more important is not only the amount of nephrons takes time, particularly still to duplicate in that time when we take care of our preterm babies, but also their arborization, which is those long sort of tubulars going deep into the kidney, are not as well developed. And we know that the metabolic processes, particularly how sodium is reabsorbed, is taking place differently, higher in the nephron than lower in the nephron. On top of that, there is a lower development of the glomerular filtration rate, the amount of fluid which goes to kidneys, which is linearly related with gestation rates. On top of that, preterm infants have high transepidermal water loss. And this graph from Hartnell, 20 years ago now, is sort of a graphical display at gestational age. Younger gestational age, you lose more, and postnatal age, also the younger you are after birth, the more you lose, because that skin needs to develop and make extra layers to stop this transepidermal water loss. As a sort of advantage in that particular balance, the preterm infants, the younger they are, will have a higher total body water content. So this might be sort of a defensive mechanisms to all these suggested changes. And how they sort of do this extracellular water contraction, which we expect after birth, there's a bit of variation into the literature about this. These little graphs show the change in total body water, and very few studies have looked at it specifically, and it seems to be sort of the same way around each level of gestation. The slope of extracellular water contraction seems to be the same. So for us as neonatologists, we have to then consider how are we going to take over this optimal fluid balance if it's not just a normal healthy term baby which can just drink his milk. We have the imbalance, which is us prescribed fluid intake and a tiny bit of metabolic derived water. We have the outs, where some of them we estimate. Transepidermal water loss is usually estimated by us. We have a urine output, which we can measure. There is this extracellular water contraction, again, which we estimate. There's some smaller amounts, and which are usually sort of omitted in this relationship, is fetal water loss and water for growth. If you look at the changes immediately after birth in either term, but also in preterm infants, I think Pollen described this already very early on, also 20 years ago, in different phases. And we talk about these phases often during the ward rounds as well. You have the pre-diuretic phase, usually the first day, sometimes up to 2 days, where there is a low urine output, minimal sodium excretion, and a negative water balance. There's a low glomerular filtration rate and variable natrium expression. What can happen then commonly is we prescribe too much fluids, or there is lower transepidermal water loss than expected. That will lead to water overload, but because of that minimal sodium excretion and variable sodium expression, we actually not quite sure on that first day what the sodium will do in relationship to that water overload. On the other end, if we didn't prescribe enough fluids, or there is a higher transepidermal water loss than expected, you get dehydration. And again, for the same reasons, because the kidneys are not completely matured yet, that is with or without a raised sodium in the serum. After the pediatric phase, diuretic phase, we get the diuretic phase, which is 1 to 5 days. It depends a bit where there is a high urine output and a higher sodium excretion, a markedly negative water balance, and increased glomerular filtration rate and excretion of sodium. During this particular situation, the common issues described, particularly after preterm birth, is that we have not prescribed enough fluid, and there are, of course, these changes in sympathetic stimulation or the RAS system. This can again lead to dehydration, and at this time, generally with a higher sodium. However, on the other end, we also have situation, and I will show you some data later, where we actually have been giving these babies quite a lot of sodium. Or there might be a situation where there is less transepidermal water loss as expected. This will then lead to sodium overload, which clinically in the serum looks exactly the same. Sodium will be high. Lastly, after the homeostasis, the third phase, which Pollen describes, usually after those 5 days, there's a balanced urine output, high sodium excretion, still a negative water balance, but increased filtration rate again, which can lead to sort of a low sodium intake. We have to catch up and give these babies enough sodium, or there is too much sodium loss, which will then clinically lead to a low serum sodium. But the complication is there are also other issues happening which affect particularly water. PDA, lung inflammation, which can lead to water retention, which can lead to edema, and BPD, where then the sodium can also be low. So I think in these couple of sort of starting slides, how we have to think about this problem, I summarized that renal water and sodium handling immediately after birth, and particularly preterm birth, is very complex and is difficult to estimate from serum sodium alone. Looking at trials, there are very few fluid or sodium trials to help guide our management, and I will go through most of them because there are not that many. This is one of the first one, 1982, that's now 40 years ago. Lawrence did a targeted a fluid intake which was targeted to weight loss in 88 babies, and he targeted either 1 to 2% weight loss per day with a maximum of 10%, or 3 to 5% weight loss per day with a maximum of 15%. And here's the graph, a representation of total fluid intake, which was of course much higher if you're not allowed to lose that much fluid. And overall, you can see if you're not allowed to lose that much fluid, you were given more fluid. And if you are allowed to lose some more fluid, you're given less fluid. The trial was quite small. There was no significant differences in any of the clinical outcomes. So it sort of led to the descriptor that, oh, it didn't make much of a difference how much fluid you gave them. When time progressed, and we're now 20 years later, more babies were on mechanical ventilation. We got younger babies as well, and particularly the relationship between fluid and possible fluid restriction, what that could do to RDS, where we know that pre-diuretic phase might be extended. This is a much larger trial, and they designed a trial protocol where there was a standard fluid regime and a restricted fluid regime, which increased every day as we would normally do in clinical practice. But this trial was actually interesting to look at because what actually happened is what's shown here. The standard actual sort of fluid load in the first 2 days of life was significantly higher than the trial protocol prescribed, and that was even more so in the restricted trial arm. And that was because in that days there was transitional hypotension, there was some other problems where we used to give quite a lot of extra fluids to maintain these hemodynamic problems. What about sodium trials? Well, I think I could only find 3 or 4, and particularly randomized trials are very rare to find. I think this is one of the first ones in 1991, where they compared a sodium intake of 1 millimole per kilogram per day versus 4 to 6 millimole per kilogram per day. And then they measured the serum of sodium, the fluid intake, and a couple of other parameters. And what they saw that if you had a higher intake, then over time you were given more fluid just to match the serum sodium within a targeted range, just as we described in the case example. Probably more interesting is when some investigators went a little bit deeper, particularly in that extracellular water contraction and what that does to the sodium and the water. This Hartnell study is very commonly quoted as sort of one of the better designed kind of studies. It wasn't big, 24 preterm infants, and they looked at the sodium balance with either giving early sodium or high sodium. They called it earlier sodium in this study of 4 millimoles per kilogram per day, or 1 millimole per kilogram per day until you reach 6% weight loss. And they measured not extracellular water contraction in this time frame. That was unfortunate. They measured it at day 14. And what they found is actually that the change from birth, whether you were given early sodium, more sodium, or late sodium, wasn't that much of a difference. And then particularly if you gave a lot of sodium, there was quite a lot of variation in what that would do to your actual extracellular water contraction, which they measured with different kind of measurement techniques. But they did conclude, though, that most of that extracellular water contraction, the water that then leaves your body, is isotonic. So what you would expect in this particular relationship and understanding that if your sodium is high, then that is most likely related to reduced amount of water within the system. Time sort of moved on, and this is probably the first one which came and showed us that, wait a minute, now fluid might have an impact on outcomes. William did a study, a very large study, but it's just a cohort study, a descriptor, looking at fluid intake and percentage weight loss. And what they found that with a higher fluid intake, the rate of BPD or death was significantly higher than BPD survival if your fluid intake was higher, as you can see here in the first 11 days of life. Weight loss sort of followed that if you had more weight loss, you're more likely to have BPD survival. Now, this wasn't a cause-effect relationship, but it wasn't randomized, and it could be related that the sicker babies got more fluid. Who knows? But this was an interesting finding, which only recently investigators sort of repeated and showed some more detail. This is one of those studies in 2021. They reported it, unfortunately, in deciliters per kilogram, so they look very close together. It's a reasonable size cohort, 191. It's in the current day and age, where indeed there was a difference, again, in the cumulative fluid balance and the outcome of death and BPD. The more cumulative fluid balance there was, the more fluid you retained, and the more likely you would to develop death or BPD. And interesting, when they looked at this weight change, they found exactly the same as O found, that there is this balance you need to find for where death and BPD doesn't lose as much fluid, and the BPD-free survivors were more likely around sort of the 10% around postnatal day 4. And also in this study, serum sodium could actually not help differentiate between these two groups or between dehydration or fluid overload. The second study looked at it actually slightly different. They didn't look at death and BPD, but because they argued that where is this fluid going? We think it goes in the lung. So we're going to look at the percentage of babies which are on mechanical ventilation at day 7, either directly related to BPD or as a fluid overload kind of thing. Very large cohort, 1,007 preterm infants. And when they looked at the cohorts, there was indeed a linear correlation between the peak fluid balance and how much baby were on mechanical ventilation on day 7. So the more fluid you retained, the more likely you were on mechanical ventilation. That effect was way more pronounced in the very young babies than it was in the slightly older gestational babies, but they all sort of behaved the same. I think that can be easily explained from physiology again. This is the Frank Starling curve, preload on the x-axis and stroke volume on the y-axis. And if you are sort of in that left hand of the curve in low volume, giving extra preload will help create more stroke volume and actually make improvements in the cardiovascular system. However, if you're already operating at a higher volume, giving more stroke volume or more volume will have variable kind of effects of what that will do. Particularly if you're already on that right end of the curve, which extra fluid would definitely lead to fluid overload. And there's not only a relationship between preload and stroke volume, there's also a relationship between preload and extravascular lung water. And if you then sort of consider, and the more fluid there is, and if you then give more fluid, it will actually end up in the lungs. If you think about what is the operating stroke volume, so the operating range of a term baby versus a preterm baby, you can maybe also appreciate why a preterm baby is way more sensitive to extra fluids than a term baby. This last study is only published just recently. Again, a very large cohort, very small babies, and they look particularly at the percentage weight change. And as you can see from this graph, there's a huge variation between days after birth and how much weight the baby's lost. There wasn't that much variation in what gestational age he was. That was actually quite interesting. And when they analyzed this data on some of the outcomes they studied, it actually became really interesting. They made graphs here of the proportion of death, which you can see on the y-axis, and on the left, you see the maximum weight loss over the first 7 days. And what they found around that 10%, 5 to 15% was the lowest point. And that cohort there not only had a lower death proportion, they also had less neck. However, the worst group was the one which had only 0 to 5% weight loss over the first 7 days. On the right, they looked at just the amount of fluid intake over the first 7 days of life, the average amount of fluid intake. And what they found is what sort of repeating of what the others found, the more fluid to give, the more morbidity has been found, more NEC and more PDA surgery. So we talk about the fluid and outcomes, and we summarize these, particularly these last recent kind of studies. There are definitely associations with morbidity and mortality and fluid. A high fluid intake is related to either BPD, death, neck, or PDA surgery. A positive fluid balance is related to mechanical ventilation or associated. And the percentage weight change was related with mortality. So these are important aspects which we can sort of appreciate now and take into consideration when we prescribe fluids. What about the role of the PDA? The PDA is a bit special in this whole sort of field. Because PDA fluid overload and the physiology behind it is actually a bit different to fluid overload of the whole body. It affects predominantly the pulmonary circulation, the left side of the heart. This is a schematic representation where blood flows from the left side of the screen to the venous system, right heart, arteries, capillaries, veins, and to the left heart. And if I would superimpose the sort of estimated pressures into each of those systems, then it would look approximately like this. In a PDA, though, what happens? You get a lower left ventricular end systolic pressure, but you get a higher left atrium pressure. So just from physiology, if you want to have flow to be the same, all the pressures in all those systems before have to be equally higher or sort of compensating for this, and the right ventricle has to be able to pump that around. And only if those systems fail, you get sort of an increased central venous pressure and maybe edema. So this PDA is predominantly focused on what happens in the right side of your heart and lungs. Pressure-wise, left side is where the volume takes place. How is PDA and BPD related? They are related because of that fluids which can build up inside your lungs, particularly in the interstitial space. We know that a PDA is related to interstitial edema. We know this from animal studies with an increased capillary alveolar distance. And what do we do as clinicians to overcome this? We either increase the FiO2 or we increase the PEEP. And both the FiO2 and the PEEP are in the definition of a BPD patient. However, when we try to close the PDA, particularly with NSIDES, this is 51 randomized controlled trials over almost 5,000 babies, then ductal patency was reduced, but had no effect on BPD. Looking here at death, BPD, oxygen at 28 days, oxygen at 36 days, or other definition of chronic lung disease. So here, the question which probably should be raised, because ductal patency was reduced, is this sort of the negative effect of NSIDES, which reduces fluid expulsion to the kidneys? This is a very difficult kind of questions. That's one way of looking at it. And another way of looking at, well, what kind of PDA are we actually talking about? And with that, I think we have progressed over time in understanding that not every PDA is the same. This is a study from El Kufash, where they looked at the probability of death and BPD by doing a PDA severity score, sort of looking at the shunt size and the size of the shunt size early on. They did incorporate gestation into their score, but also PDA diameter, the flow pattern, how blood flow, particularly of the left ventricular output was, and the myocardial velocities. And you can see those little gray dots. There is overlap, certainly between sort of score of, say, below 6, but above 6. Then most of these babies would have either developed the outcome death or BPD. So PDA shunt size seems to be related to BPD. Not only shunt size, exposure duration also become important, and I'm going to show you just 2 studies, but there are multiple more showing that same thing. The longer you are exposed to your PDA, the more likely you have the outcome risk of death and BPD. Not only is it the shunt size and the exposure, but what about the 2 of them together? And then looking at the grades of BPD, not just any BPD. This is a slide from Kleiman, who sub-analyzed his PDA Tolerate trial, 176 preterm infants, very young, less than 28 weeks, and they only reported here on the severest form, grade 2 and 3, and the incidence there. And what you can see in this graph, what I really like, is this linear relationship between a closed or a small PDA, the duration of this exposure to a moderate and large PDA. The longer you are exposed, the more likely you're going to have BPD. And that makes sense. In this graph, he sort of puts this in this, and we like little graphs and flow diagrams, don't we? So we look at this fluid volume replenishment leading to volume overload, which leads to a PDA, but also to increased lung water, and on the lower side, the more systemic effects. PDA leads then to congestive heart failure, and together with that increased lung water leads to BPD. I'm going to put something else in here, which I call diastolic dysfunction. It is something different than just increased lung water or the PDA or congestive heart failure. It describes sort of the step before all of this happens. And we found a relationship, particularly between this diastolic dysfunction and the PDA and other outcomes as well. Diastolic dysfunction is the impairment in some of all of the components of diastolic function, so how the heart fills, which is 4 of them: relaxation, recall, stiffness, and left atrium function. And whatever is abnormal, they result in an increased left ventricular and diastolic pressure or a raised left atrium pressure, as we often see in the PDA. You can measure this diastolic dysfunction with Doppler and ultrasound. This is an example of pulse wave Doppler in black, which measures the blood flow velocity, or tissue Doppler in red, which measures the myocardial tissue velocity, starting in systole, S prime and S, and going into diastole. And the E wave is usually early diastolic function, which is passive, and the A wave is the atrial function. And you use a numerous amount of measurements looking at relaxation, recall, stiffness parameters, and aging function. And you can use a multi-parameter approach to see if a patient has diastolic dysfunction. So we looked at this in one of our studies in 126 babies, and we looked at the cumulative risk of diastolic dysfunction using this multi-parameter approach. And we saw, just as Kleiman studied, that with increasing postnatal age and increasing exposure to PDA, there was an increasing risk of finding this ultrasound finding of diastolic dysfunction. Mm-hmm. In a more recent study, in 98 patients, we found that, if you look at one of the commonest parameters we usually use in the PDA, which is the PDA in diameter, which is shown here on the y-axis. If you then sort of differentiate between the babies with no diastolic dysfunction or diastolic dysfunction, there was a huge overlap. Above 1.5 millimeter, a little bit over half had diastolic dysfunction, but over half didn't. What was really interesting in this particular finding is that these babies who then had a large PDA and diastolic dysfunction were more likely to show respiratory signs and symptoms, which is the definition of diastolic heart failure. So if it comes to the PDA and its role with the development of BPD, the summary is that it is related to shunt size, the duration of the exposure to the PDA, and whether or not there is presence of diastolic dysfunction. So going back to this graph and where this diastolic dysfunction sort of appears, some would argue, well, that's the same as congestive heart failure. I probably would agree, but I guess diastolic dysfunction happens before, and you can have an ultrasound findings of diastolic dysfunction, and then you have a higher risk of developing congestive heart failure. But like any graph, there's always something more. And one of the things we haven't talked about much is sodium intake, and high sodium intake in particular. This study from Eibensteiner showed, and what they did, they had 19 very low birth rate infants, and they measured and calculated meticulously the sodium intake and the serum sodium. And as you can see, that the sodium intake was, on day 1 around 6. And then it became around 10 and sort of fluctuated around that, 8 to 10 millimoles per kilograms per day. But if you then sort of consider what the SBAN recommends, particularly in the first two days of life in the pre-diuretic phase, it is actually 1 to 2 millimoles per kilogram per day. So we are giving way more sodium than is recommended, and that will have an effect. Where's that sodium in? That sodium is in everything we prescribe. It's in antibiotics, in your arterial line, in caffeine. There's a huge amount of sodium in blood products, particularly albumin, huge amount in phosphate, and there's actually variable amount in fluid intake, or your TPN. And all of these medications are regularly used in the first day of life in our very young babies. What was important, what they found and what they reported. So for every millimole extra sodium, they calculated some outcomes. And they found that the maximum sodium, serum sodium, was interestingly not associated with extra intake. That was actually surprising, but maybe even more surprising, that a higher sodium intake for each millimole extra was associated with BPD, particularly of high sodium intake in the first postnatal week, still present there in the second postnatal week, and with NEC, where high sodium intake on the second postnatal week was associated with NEC. How does this work? Well, how do you get sick from high sodium per se? And the explanation they provide is coming from sort of the understanding of what the Adult Cardiology Network has about sodium and where sodium plays its role. And they think it all has to do with the interstitium, the extracellular network, which is not in the plasma and not in the cell. Because that's a network of glycosaminoglycans GAG, it's called, GAG networks and collagen fibers, and how they interact with each other is through electrostatic interactions, and particularly sodium plays an important role here. So if we put that in perspective, that with a normal sodium intake and a normal oncotic pressure, this network works really well. And it connects, of course, with the lymphatic system, which is supposed to take all that fluid out of the interstitium and bring it back into the capillary network. However, with a higher sodium intake, the GAG network can compensate by sort of getting bigger and getting bigger in size as well, but at a cost, at a higher oncotic pressure. This high interstitial sodium actually stimulates to making more lymph vessels and lymph angiogenesis. They can get a little bit bigger, and it increases the lymphatic capacity. So that's how the system sort of stays in balance. But at some point that can go wrong when there is an increasing or continuous high sodium intake and maybe another disease on top of it. You get a decompensation and a dysfunctional GAG network. At that point, you get lymphatic fluid extravasation, which you would clinically see as edema. I'm going to sum it all up and see if we can get to finding the perfect balance. I'm going to tell again, renal water and sodium handling immediately after preterm birth or any birth is complex, but it is difficult to estimate from serum sodium. And there's now new data which I presented, which suggests that we're not providing optimal water and sodium intake early after preterm birth. I have shown you some data that a high fluid and a high sodium intake is associated with morbidity and mortality, but still many clinicians would prescribe more fluid for high sodium early after birth. That very old sort of adagium which is there. And when I read all this literature, I did an audit of our local practice. I just took a very small audit, and I would encourage you to do the same in your units. Look at 10 babies which are very small and see what actually happened in your unit. These were 10 babies less than 750 grams. I took the youngest and the smallest, and I looked at the sodium intake, and it was exactly as was described by Ebenstein, about 8 on the first day of life, but some even higher, and stayed around that particular level, much higher than ESPAN recommended. What followed, of course, that the serum sodium would go up, just as in our case, and the discussions in the notes describe, is this higher water loss than anticipated? Is this dehydration? And almost nobody describes or calculates the cumulative sodium intake over that first day of life. Then it is followed with an increase in total fluid prescription, which is again higher than is recommended and follows each day. So the cumulative amount of fluid in those first couple of days is also high. What it then relates to, which was actually a bit of a surprise, that indeed some of the babies have not a lot of weight loss. Only 4 of those 10 we could maintain in this sort of targeted range, but there were actually still 3 of them which had way more weight loss than anticipated. So the message here, I guess, is that in the search of this optimal balance, something needs to change. And I think what happened over time, this is a timeline of how we got to our understanding, how we learned from our mentors of what to do, is that it started with early on there was a high sodium was most likely related to a high transepidermal water loss. So more fluids would be beneficial. Then we got this phase where Martin is one of them, described this phenomenon with more mechanical ventilation and more transitional hypotension or transitional low blood flow, and more fluid resuscitation was prescribed. Then we got this phase where the ESPAN recommended that all these preterm babies need to have more caloric intake. And to sort of stamp that all into the total fluid was actually difficult. So often we went up with the total amount of fluid prescribed. And there's this last sort of description where people describe the refeeding syndrome and the seriousness of that refeeding syndrome. So you need to start phosphate early, which is packed full with sodium. On the other end, as sort of a positive things, we have less mechanical ventilation, more antenatal steroids, and less transitional issues. So we don't need as often that fluid in them. We have delayed cord clamping there, but what I think is really important, what changed the loss, I think we have a lower transepidermal water loss than the textbooks describe. And the reason for this is very simple. Look at the cribs from back in the days, single wall incubators, variable humidity, poor distribution of air, and these, Rolls Royces, which most of us will have, double or sometimes triple wall incubators, high consistent humidity and air boost. And the Japanese did some great studies, and they showed us that, this is currently the transepidermal water loss. And as you can see there, the 22 weekers stick out on day one and having quite a high transepidermal water loss. But then they sort of all balance out sort of after day 3 or so. But if we looked at textbook data on transepidermal water loss of 25 to 27 weekers, then it would be this red line, which is comparable to 22 weekers. So if you treat 22 weekers, you're still doing the right thing. But if you're treating 25 to 27 weekers, maybe on day 1, the transepidermal water loss is much less. And maybe we should give less fluids to these babies to begin with. So the title of my talk was, do fluid, sodium, or the PDA have anything to do with the PDA? And I think with BPD. And I think that the straight up answer is a bold yes, it absolutely does. It is described in this editorial, which I really appreciated, that early postnatal fluid balance, it is time to pay attention. It is difficult during the immediate postnatal period. Fluid balance in preterm infant is dynamic and complex. And I showed you in our little audit that some of them, even though prescribed on high fluids, still had a lot of weight loss. So where do we go from here? What will be my suggestions for discussion and debate is, first we need to realize and say to ourselves that high sodium early after birth, and probably even thereafter, it does no longer equal dehydration. It can also be something else. So serum sodium after birth should only be interpreted with knowing your fluid balance and knowing if your sodium balance would be ideal. But let's start with the sodium intake. We should try and target our sodium to the ESPAN recommendations, but looking at where sodium is all in, this is a very difficult ask to get the sodium load to 1 to 2 millimoles per kilogram on day 1 and 2. But the last suggestion which came forward out of these papers, and I do appreciate that one, maybe we should adjust our fluid to the individual patient's percentage weight loss and target an optimal of around 10% around 3 to 5. This will be easily manageable and doable by, for instance, doing daily weights and seeing where you end up. Here's where I'm going to close off, and we have time for a chat and discussion.
Thanks very much, Koert. A fascinating talk, and really making us think a little bit about, or a lot about, our early management of babies, and that the housekeeping management of fluids, deciding on the fluid rates, what type of fluid we're going to give. We can't just rely on the old history. I think we need to start rethinking, as you pointed out. So it's a great stimulus to rethink the way we prescribe our fluids in the nursery. And then that relationship to PDA and BPD, 2 very important outcomes. Again, is there something we can do to reduce the impact of fluids on those 2 conditions, which are clearly 2 of the conditions we have to deal with very often in the neonatal unit. So there's a few questions. First one from Mike Byrne. Does albumin equal transfusions? Does albumin or transfusions affect the transepidermal water loss? Is that a relevant concurrent management consideration? So I suppose talking about blood products and transepidermal water.
Yeah. To be honest, I don't know out of the top of my head of that particular question has been focused. So most of the focus on fluid early on has been on indeed what it does fluid-wise. Now, particularly that last data I showed where it actually can be the sodium as well. And as I told you, albumin is probably the highest sodium product you can find in your cupboards. Might be much more important in, say, a baby who already has like a sepsis and already has fragile capillaries, and how that sort of balance between the oncotic pressure and the capillary pressure would work. So I don't have an answer for you, what that means. I think it might be important, but I think we have not studied enough the aspect of sodium by itself.
Thanks, Koert. Another question regarding weighing the baby. Do you weigh the baby daily during the first several days of life? And what's the relevance of the weight in this setting?
So at this moment, we are not. We are mulling over this data. But for me personally, yes, that will be my suggestion. I think doing a weight daily where you can target and find that lowest point and work your way to that target, because we can estimate as transepidermal water loss. We sometimes find it difficult to measure urine and fetal losses at the same time. The amount of fluid which is described can vary, even though we have electronic prescribing. But the end goal is the weight. So I think the weight would be, for me personally, and I would suggest that in the very small babies to just maybe we can build a strategy. And I would imagine that there will be some colleagues online here, particularly from the Japanese society, who might already do this.
So if anybody from Japan would like to comment on this fluid management, because we know that that's a very important tenet of this management of in the Japanese neonatal intensive care units, that would be great. We often, when we weigh babies, we find there's a discrepancy where, I mean, I think it's really just reflecting what you've said, Koert, is the sodium level can be high and babies who've lost a lot of weight, and sometimes the sodium level is not high in those babies. And then we're not sure, we see that as an incongruity, but really it's not. It's, what you're saying, there are two different processes that we're looking at here. We're looking at fluid and we're looking at sodium. And the baby with the high sodium and the high weight loss is probably a baby who's had more sodium given to them. It's not necessarily that the high sodium is due to the dehydration and weight loss. And we need to sort of break that sort of link that we have had since, as you pointed out, the 1980s and 90s. Yeah.
Look, in a comment particularly on the rationale why we want to give more fluid, I think is predominantly to protect the kidneys. And that makes a lot of sense. If you get early kidney injury, that is associated with further morbidity down the track and even mortality. For that particular aspect, I think we need to pay more attention to the actual blood pressure and the blood pressure changes. And particularly in this case, the very first day blood pressures were 65 and 67 systolic. The next day it was 55 systolic. Now that sounds all normal for a 560-gram baby, but that's a significant decrease. And particularly the kidney is very sensitive to pressure changes with how it can increase its glomerular filtration rate.
So comment and question from Brett Manley. Wonderful, Koert. My take-home message is it's complex. We don't know what it's best to do. I'm not convinced about the traditional teaching of the association between early fluid intake and BPD, especially now we're caring for 22, 23 weekers. And we may need to use way higher fluid intakes in the first days. Your thoughts? Yeah, so in my own little audit, we saw that even though we gave way more fluid to all of them, there were some babies who still lost, over 15%. And I agree with you. Those babies need more fluid. You should probably not lose that much of your original weight unless you have hydrops or something, but otherwise you shouldn't. So an individual approach is probably the way forward. I do think there is a relationship between too much fluids. That is pretty clear. If you do not lose a lot of weight, that association is, in my opinion, pretty strong. I mean, one of the complicating features is hyperglycemia and the sugar-containing, what pathway or what fluids do we use when we wanted to actually give fluid? And given the issues you brought up with sodium, what about the glucose solution? We had a talk earlier in the week about the adverse effects of hyperglycemia in this group of babies. How do we bring these two together?
Yeah, no, I have to. We struggle with that. We sat down with the pharmacist, and what can we dissolve in something else? And some of the antibiotics can go in water. Your arterial line can go into half. So the saline, but others you cannot get the sodium out. There's still a lot of sodium in penicillin itself. There's still a lot of sodium in the phosphates, which I don't think there's another preparation for it. So, so you're correct. this ask by ESPAN to give, a 500 grammer, 1 millimole to 2 millimole of sodium per day is almost impossible.
Should we consider using fluid boluses during initial resuscitation?
Normal
saline bolus.
Yeah. Look, no. If you think the baby is hypovolemic and that's why you're giving a fluid bolus, I think you should still use a crystalloid. I think that makes sense, and almost all crystalloids will have a similar account of sodium into it. In the various some centers might still use albumin as a volume replacement that, for instance, contains way more sodium than crystalloids. So I wouldn't reconsider that. If you give if you give fluid boluses for acidosis, I think that's very different. That's where you need to reconsider what it is you're actually trying to achieve.
So, a question from John Sin. Given your presentation of sodium findings in the second week, should we be looking at frequent urine sodium measurements?
Oh, that's a really good one, because I like that one again, because calculating the fractional excretion of sodium is not that hard if you just have, your daily sodium content in the urine, and we get a better appreciation, particularly in that third phase, which is a very different phase, where we all sort of try to run behind, the low sodiums and giving these babies more sodiums. And I think looking at the fractional excretion of sodium would be a good suggestion, diagnostic suggestion.
How about flushing intravenous antibiotics? When we flush the tube after the antibiotics, should we use normal saline or water? And is that an important component of the total sodium?
I think Eidensteiner calculated that particularly on day one as being like 10%. And that depending on your local practice with how much you flush it. Look, I don't think you can flush a milliliter of water without sodium into a 500 gram baby without, expecting significant changes in the osmotic pressure at that local place where you inject. So I wouldn't recommend flushing with water at this moment. I think we need to have some more information of what that could do.
So just getting back to the relationship between BPD, PDA and fluids, one of the tenets of conservative management of PDA, both acutely and long-term, is restriction of fluids. And in particular, there's some studies in that first couple of days of life showing that restriction of fluids with a PDA at that period potentially reduces cardiac output, at least as measured by SVC flow. So is that an issue that may be part of the harm, for example?
So, look, this is there's different phases of the PDA where fluid restriction might be helpful and where it wouldn't be, and then there's different levels of fluid restriction. If you look at the Korean data, they restricted their babies to about 110 to 130 for weeks on end, but their level of acute kidney injury in those particular populations were actually quite high. So I'm hesitant with fluid restriction for a PDA. Look, if you're on 200 and you're growing well, I think you can go down, certainly. But I generally wouldn't go much lower than 140, 135, because the fluid is also required for other reasons. I think you're better off treating the PDA.
What kind of crystalloids should be used for these babies?
So the general recommendation is still sodium, so normal saline. There are different variations in adult ICUs, etc., and combinations in very, very sort of rare diseases where there is a very high sodium. I don't think we have enough information in neonatology to give you another advice than the safest we know, which is just normal saline.
Question from Christian Theda. I worked with a neonatologist who gave sterile water via nasogastric tube at about 10 mils per kilo per day, tolerated well. Is that something we should be thinking about?
Ooh, it sounds like feeding, isn't it? Breast milk doesn't contain much sodium as well, but at least it contains calories. So no, I wouldn't think of that as a suggestion for 2022.
Okay, well, we're just about to hit time. Any other final questions or comments? Yeah, thanks. You answered a lot of questions in a short time there, Koert. So thanks very much for that. One last one. Saline causes hyperchloremic metabolic acidosis, and the relationship to renal bicarb loss. Is there anything quickly that we can?
So remember when I showed you the slide of the arborization of the kidneys, and particularly the younger in gestation has less capacity to do that kind of transformation which you talk about. Now that will be a whole talk by itself, to talk about that relationship between the sodium chloride and the acidosis in preterm babies. I'll leave that for an enthusiastic pediatric nephrologist to do that for us.
Okay, well, just remains to thank Koert very much for another fabulous talk, as always, and just so clearly presented, and great summaries of the literature. So thanks for a great talk, Koert, and thanks to Julie and the team for continuing this great range of talks that we get each Thursday. It's a smorgasbord of interesting topics, and it's always great to attend. So thank you to the team for arranging yet again.
Thanks, Martin. Rahul, is there a talk next week, or is this the last of the session?
We have a couple of weeks off. So our next talk is on December 1st. It's on laryngeal mask airways. So okay. We will send out the invites soon. Yeah.
All right. Thanks for organizing, Rahul.
Thank you so much.
Thank you all.
Thank you.
Bye.